Hi, Mike Gibson coming to you live from SCAI 2015, and I'm joined by Aravinda Nanjundappa. Aravinda, welcome today.
Thank you, Dr. Gibson.
So, critical limb ischemia, why is it so important?
So, critical limb ischemia is advanced stage of peripheral vascular disease, which involves like Rutherford 4, 5, 6. That means rest pain, small ulceration to a large ulceration, which is impending limb loss. So those patients have a high mortality if untreated, and it is not.
I was dumbfounded by the number when you and I were talking, a 25% mortality at 1 year.
Absolutely, and the 25% mortality is not because person is going to lose the leg and is going to die tomorrow or because of sepsis. That's only a part of the picture. The absolute problem is the concomitant cardiovascular disease and the cerebrovascular disease that you see in PAD patients, which is the natural history of them. Once they have CLI or critical limb ischemia, the 25% mortality comes from combined myocardial infarction and stroke.
Well, is it split about half and half or more weighted towards MI or stroke?
It's actually exactly half and half. The 10-year data shows it's 25% patients lose from myocardial infarction, about 20 to 25 from stroke. Absolutely.
Wow. Amazing. So what have been some of the recent advances in managing critical limb ischemia?
So the key with management of critical limb ischemia is when you see patients with rest pain or leg ulcers, the key thing is to determine is it related to a pressure sore that patient in a nursing home got it versus the garden variety one, which is from underlying diabetes, advanced atherosclerosis, and tobacco use. So the key thing is we are more aggressive on guideline-based medical treatment. The appropriate use criteria is coming up for these patients with critical limb ischemia also. So we want to treat them with antiplatelet therapy, smoking cessation, lifestyle changes, diabetes control, ACE inhibitors, and statins. Yes, they have helped in managing better, but the key thing is we need a good duplex examination with a physical exam to document is there any absent pulses, is there reduced pulses, is there reduced flow, what is the ankle brachial index, what is the toe brachial index. We can even get pressures in the foot to say whether the wound will heal. And if it's not healing, get a multidisciplinary approach between a vascular surgeon, an interventional cardiologist who is trained with this, and an internal medicine specialist, and even people like endocrine podiatry together.
Right. So really it's a team approach.
It's an absolutely team approach.
It's a multidisciplinary approach.
Yes, and this again incorporates the fact that vascular medicine and vascular intervention is a multidisciplinary team approach. And then proceed with doing an angiogram and then trying to treat the lesions either by endovascular or surgical approach. Of course, there's always an ongoing debate who is better, and I think we need to move away from the fact that who is better. I think the key is
what is better for this patient?
What is best outcome for the patient? What can I achieve for limb salvage? If you have a long piece of single vein that the surgeon can use, the heart is in a good condition, his stress test is negative, the patient has minimal comorbidities, they can do a good femdistal bypass. Even today, surgery is a good option. At the same time, if the patient has advanced diabetes, dialysis, they can't get a single piece of vein, his heart function is weak, probably endovascular approach is good.
Had a lot of frequent flyers with this disease. You know, they have that intervention, come back a lot. I've seen them come back 5, 6 times. How are we doing in terms of coated balloons, coated stents, in reducing that recurrence rate?
That's an excellent question. So when you have the numbers reduced with a very reduced flow, still you can keep the skin intact. But once the skin tissue breaks, the amount of blood flow you require to make the wound healing is really, you need adequate flow. So to answer that question, in the past, the crossing techniques, that means to establish a blood flow itself, a straight line flow, that means through SFA, popliteal, one of the arteries, was the essential key for critical limb ischemia. We used to use balloon angioplasty, plain old balloon angioplasty all the time, and the success rate for that was about 80%. But then again, the restenosis rates is anywhere for balloon angioplasty between 50 to 70%, so you really need more durable treatment. Then came the bare metal stent by trials, which showed some promising, but the restenosis rates were again high.
Sure.
So then the various trials like the Achilles trial, the Yukon trial showed that if you use drug-eluting stents, the patency is better, the restenosis rates are low, there is an amputation benefit, there is also a survival benefit. But the cost of the drug-eluting stent is very high, then you have to take aspirin Plavix for a duration of at least 6 months to 1 year. So the new concept came with the drug-eluting balloon. However, there is no data on drug-eluting balloon below the knee. One of the clinical trials that was started by Medtronic was stopped prematurely because they had higher amputations with the drug-eluting balloon compared to the conventional balloon. Although the trial took on patients who had more advanced ulcers in the drug-eluting balloon arm, and by statistics,
in small numbers. And
small number, and I think statistically, absolutely right that maybe they took on longer lesions. But however, the trial was prematurely stopped, and now we have an ongoing trial headed by Jihad Mustafa and another vascular surgeon, Patrick Garrett, where evaluating a Lutonix balloon for below knee with paclitaxel. We are almost close to half the enrollment, so time will tell whether this is going to work.
Great. What do you see coming along in the future?
So the last 10 years, I think what has shown is way back in the late 90s, some of the pioneers of endovascular intervention like Dr. Sri Iyer and also people like Gary Ansel did pedal access. That means just like how we're doing radial artery access to reduce femoral complications, they were doing pedal artery access to increase the crossing from retrograde femoral or antegrade femoral. The crossing is about 80% plus. But if you use a pedal artery access and then cross the lesions, your success rates are more than 95%.
Amazing.
But unfortunately, in these pioneers, when they're using big sheets and they were afraid about damaging the distal vessels. But recently, more innovative operators and the younger operators have figured out just to use a 2.7 French, just a micropuncture sheet, get up there and then use a wire till the popliteal level, then snare the wire from the top, use a cart technique or a reverse cart technique. We even call it safari or a rendezvous technique, and then deliver the therapy from antegrade.
Wow.
So now the success rates are 95%. You can deliver most therapy from a small puncture from the foot. So going back to your question about repeated patients who used to come back for restenosis because of incomplete treatment. Now we are able to offer more complete treatment. So in a nutshell, I would say if you can treat them endovascularly for advanced ulcers with a stent, maybe for a short ulcers or wounds with a simple balloon angioplasty, your recurrence rates are going to be lower. But you do need aggressive surveillance. At the same time, I think we need to continue to keep the option of bypass as a good viable option, keep the surgeons involved, not just for wound care, but for our possibility of fem bypass and our patients who need surgery. And this is best going to be addressed with a new clinical trial, which has been NIH funded, called BEST, which is going to evaluate the modern day techniques of angioplasty stent versus a conventional bypass. And I think that's a really good trial, and I would encourage all the clinical trial people to enroll in this patient.
Participate in it.
Great.
Aravinda, thank you so much for joining us today.
Thank you, Dr. Gibson.
Thanks for bringing us all up to date. And thanks
Always
to
a
all
pleasure.
of you.
Thank you.
Thank you. Thanks to all of you for joining us here live from SCAI 2015.